So a wonderful good afternoon as well as good morning. A wonderful good afternoon to everyone, the entire community on the call. Would like to welcome you and just pass our regards to you, wherever you are hearing us from, to all the 34 participants on this call. If you're able to get us, please, you can respond by saying a hi back to us. Thank you. Are we audible? Can someone kindly confirm for us if they're able to get us? Thank you. Okay, so the time is 12:06. We'll go ahead and start our echo session for today. Let me start by greeting everyone on the entire community on the call. Again, thank you for those confirmations. I think we've been able to see on the chart that you're able to get us. We did forget that I think we've muted everyone on the call. Thank you for those responses. So to start with, I would like to warmly welcome the entire community, all 46 of us on this call, to this wonderful echo session for today. My name is Zoran Muhimba. I'm a consultant pathologist from the Department of Pathology and Microbiology at the University Teaching Hospital. Yes. And as you all know, antimicrobial resistance poses a very serious global threat to the animal health and environmental sectors, with sub-Saharan Africa bearing the heaviest burden of these resistant bacterial infections. And it is from this background that today's session will be looking at an aspect of objective number 4 of the Zambia Multifactorial National Action Plan on Antimicrobial Resistance, which focuses on optimizing the use of antimicrobial medicines in the human, animal, and plant health. And that is why today we're looking at the topic on the AWaRe classification of antibiotics. And to help us discuss this wonderful topic, I have here with me one of my colleagues, as well as one of the key players in the antimicrobial space in Zambia, and that is Dr. Steward Mudenda. So Dr. Mudenda is a renowned pharmacist, researcher, and academic with a strong passion for improving healthcare outcomes. He holds a Master of Science in Clinical Pathology, Master of Science in Public Health, and the PhD in a related field. He has made significant contributions in the field of pathology with focus on antimicrobial resistance, as well as infectious disease, amongst other things. And he will be taking us through this presentation on AWaRe classification of antibiotics. After he presents, this will be followed by a case presentation by Dr. Bwaliambulo, who is a registrar in internal medicine and infectious disease here at the University Teaching Hospital. We also have a panel of experts who will be joining us today on the call. And let me just quickly mention the panel of experts that we have today. So we have Ms. F. Makiko from the University Teaching Hospital. We have Mr. E. Chambula from UTH as well, Ms. N. Kaunda from UTH, Dr. Kapolowe from Levi Mwanawasa University Teaching Hospital, Dr. Matele from Levi Mwanawasa University Teaching Hospital, Mr. S. Zimba from Ndola, from NHH, which I'm assuming is Ndola Teaching Hospital. Oh, sorry, the National Heart Hospital, sorry for that. Then we also have Mr. E. Chikatula from Levi Mwanawasa University Teaching Hospital. So with that, I will now hand over to Dr. Mudenda, who will take us through today's presentation that is on the AWaRe classification of antibiotics. Dr. Mudenda, please go ahead.
Thank you so much, Dr. Zoran Muhimba, for the introduction. And like you said, we are here to discuss on how we can optimize the use of antibiotics for our patients and to improve patient outcomes. So it is my passion to disseminate information regarding appropriate use or rational use of antimicrobials. So today, as your presenter, I'll take you through the WHO AWaRe classification of antibiotics. Our session objectives include, as we complete our session, I would like each one of us, and then apart from us, those who are not with us, we share with them about the AWaRe classification of antibiotics. So we'll describe the access group of antibiotics, then we'll discuss the watch group of antibiotics, and lastly, the reserve group of antibiotics. So together, the access, the watch, the reserve, they make up what we call AWaRe classification of antibiotics.
Thank you, Dr. Mudenda. So we'll go straight ahead and start our first poll question. Can we kindly launch the poll? Okay, so the first poll is asking the question, what is the goal of using the WHO AWaRe classification of antibiotics? I'll repeat the question. What is the goal of using the WHO AWaRe classification of antibiotics? And we have 4 options. Option A is responding that the goal is to monitor antibiotic consumption and the effects of stewardship policies. Option B is mentioning that it is for the purpose of optimizing the use of antiviral agents. Option C, to reduce the use of antifungal agents. And option D, to increase reserve antibiotic usage. So we have a minute to respond to this poll. Currently, we are at 34%. That is translating to 27 of us have managed to respond. So within the next minute, we'll be closing this poll. Thank you for those responses. We are now at 60%. Please continue responding based on what you think is the answer. Okay, so the poll has ended. We mentioned it was within 1 minute. So I'll hand over back to Dr. Mudenda to continue with the presentation.
So thank you so much for the responses. And the responses you make will help us to either come up with strategies to improve information about this topic. So we've seen that most of our participants have chosen the answer A, to monitor antibiotic consumption and the effects of antimicrobial stewardship policies. So we're going to into the main presentation of the day. I'll start by introducing what antimicrobials are, and then I'll delve into the AWaRe classification of antimicrobials. So the first thing we need to know is antimicrobials are drugs that are used to treat infections. So we know of antibiotics, we know of antivirals, antifungals, and then antiparasitics. And there are many infections we can give as examples. We can talk about TB, we can talk about HIV, we can talk about meningitis, UTIs, STIs, and other infections. So since these infections are caused by microorganisms, the only way we can treat is to use antimicrobials and antibiotics to treat bacterial infection, antivirals to treat viral infections, and so on and so forth. But unfortunately, despite a milestone which we reached by coming up with antimicrobials, there's been a challenge of antimicrobial resistance. We've been overusing and misusing our antimicrobials. And this inappropriate use has contributed to the emergence of antimicrobial resistance. And this is the reason why we're trying by all means to come up with strategies to reduce the overuse and misuse of antimicrobial agents. One of the things that has contributed to the emergence and spread of antimicrobial resistance is non-adherence to treatment guidelines. And one of the treatment guidelines which has been developed is now the AWaRe classification of antibiotics. So in 2017, therefore, the WHO established the AWaRe classification of antibiotics. So from this AWaRe, you can see the A stands for access, the WA stands for watch, and the RE stands for reserve. So we have the access group of antibiotics, we have the watch group of antibiotics, and also the reserve group of antibiotics. So the reason this was developed is to monitor antibiotic consumption and also to define targets as a facility or as a country, and to monitor how our antimicrobial stewardship policies and programs are working towards combating antimicrobial resistance. One thing we need to know is that when a patient comes to the hospital and we are seeing them, we want to prescribe medicines, our goal should be that we prescribe the right antibiotics for the right patient at the right time, the right dose, by the right route, and for the right duration. So the right antibiotics can only be prescribed if we know the condition that we are treating. Okay, and that is why the AWaRe classification of antibiotics was developed to optimize antibiotic use, and this will lead to improved patient outcome, reduce the emergence and spread of antimicrobial resistance, and also reduce or limit the spread of multi-drug resistant organisms. So as we prescribe antimicrobials for our patients, let us always remember these goals, okay? To reduce the emergence and spread of antimicrobial resistance by ensuring that the patient receives the best antimicrobials that they need. The WHO AWaRe classification of antimicrobials has the access group of antibiotics. You can see from bottom there going upward. So access, these are the antibiotics that must be very, very readily available in all facilities. They've been proposed to be used to treat common infections globally. So they must be available at all times. And then we have the watch group antibiotics. Before we use watch group antibiotics, we need to ensure that a patient maybe has been put on the access group antibiotics. The thing is, access group antibiotics have less potential to develop antimicrobial resistance compared to the other groups of antibiotics. Okay, so we need to monitor how we are using the watch group of antibiotics. And then the reserve, these are reserved antibiotics. They are the last resort. So we use them when the watch group antibiotics have failed. We use them to treat multi-drug resistant infections. You know, there are infections where you use access group antibiotics or watch group antibiotics, but the patient is not recovering. So in that case, you avoid using, you reserve the reserve antibiotics so that they can be used for those severe infections. Okay, so here again, it's almost the same pictorial presentation as the other one. So the access group of antibiotics usually are used for empiric treatment of common infections. Then the watch group, these must be used carefully, especially the use of these drugs in hospitalized patients, because you find that most of them are injectable antibiotics, and then we cannot be using injectable antibiotics for patients who are not hospitalized. You give them injectables that go and use at your place. It's not right. So we need to monitor well the use of the watch antibiotics. The reserve, like I said, the last resort of antibiotics. So just going into detail a bit for the access antibiotics. So they are mostly narrow spectrum antibiotics. And in terms of price, they are lower cost. And in terms of safety, they have a good safety profile and a low resistance potential. And that is why they are used as first or second choice treatment for the common infections, okay? So they should be widely available. So we're saying that facilities should have these access antibiotics available, and they should be affordable. And when we talk about quality, they should be of good quality, of course. Some of the examples of access group antibiotics, we have the common amoxicillin, which we call amoxil, metronidazole, that's Flagyl, phenoxymethylpenicillin, that's Pen-V, then cotrimoxazole, that's Ceprin, and also cephalexin. So the list is quite long. So these are just some of the examples that I chose to add in this presentation. Dr. Muhimba.
Okay, thank you. So far, hope you're enjoying the presentation by Dr. Mudenda. So we have our second poll question. Can we kindly launch the second poll question?
Yeah.
Okay, good. So the second poll question asks, watch group antibiotics have a high potential for resistance compared to access group antibiotics. Watch group antibiotics have a high potential for resistance compared to access group antibiotics. And we have two options, whether this is true or false. So we encourage you to participate in this poll. Currently, we have 42% that have managed to respond to the poll. We have about 20 seconds. Please feel free to indicate your option. Remember, this is for purposes of just helping us understand what the community knows in terms of these poll questions. Yeah. Okay, we're at 65%. Okay, so I'll be ending the poll now. So I'm going to share the results so that we can see where we are. Okay, I hope you're able to see. So for the second poll question, 75% of us, that is translating from 61 that responded to the poll, are saying that this is true, whilst 25%, that is 15 of the 61 that responded, are saying false. So thank you for responding to the poll. We'll be able to discuss these poll questions at the end of the presentation. So we'll get back to Dr. Mudenda now to continue the presentation.
Thank you so much, Doc, again. So now I've discussed the access group of antibiotics. So now we move to the watch group of antibiotics. So the watch group of antibiotics, usually these are broad spectrum antibiotics. And when we compare to the access group of antibiotics, the price is quite on the higher side, right? And the resistance potential is very high when you look at the watch group antibiotics compared to the access group antibiotics. And that is why we're saying that these antibiotics should be used carefully and they must be monitored, especially for our hospitalized patients. They are also recommended as first choice options for patients with more severe clinical presentation. So we're saying that someone who comes with a cough or maybe a fever may not need to be on these antibiotics. They should be reserved for patients who have severe conditions. But in most facilities or during our practice, we see that our practice is actually against what these guidelines are trying to help us achieve. So we also use them when there are some resistant pathogens where access group antibiotics cannot work. Okay, so some of the reasons why we have to monitor the use of watch group antibiotics is to avoid emergence of resistance towards these antibiotics, and also to help us set up stewardship programs. So we're talking about antimicrobial stewardship programs where we optimize or promote the rational use of antibiotics. So some examples of these watch group antibiotics include ceftriaxone. We also have meropenem, azithromycin, ciprofloxacin, and vancomycin, and many other drugs. There are about 110 of them. Now, you'll see that in our practice currently, we're overusing ceftriaxone. We also overuse or misuse azithromycin. We also overuse or misuse ciprofloxacin. So these practices will actually lead to the increased antimicrobial resistance towards ceftriaxone, towards azithromycin, and ciprofloxacin. And as healthcare workers, we need to guide. We need also to share this information so that we follow the guidelines. Then the last we have are the reserve group antibiotics. Like I said, these are reserved for severe infections, especially those infections caused by multi-drug resistant pathogens, because the access group of antibiotics you'll find that may not work, and also the watch group of antibiotics may not work. Not that they will not work, may not work. They might work or they may not work. So if they don't work, then we have to use the last group of antibiotics. So these also must be protected. So we're saying let's reserve them. Let's protect these antibiotics from the few antibiotics that we have. Let us protect these. We shouldn't misuse them, so that when we have MDR infections, we can now come to these antibiotics. So they need to be monitored. And in some facilities, or in all the facilities, you find that starting from the watch group antibiotics and the reserve group antibiotics, those who prescribe must be known. Actually, it's not everyone who should be prescribing watch group and reserve group antibiotics. It's the senior people who have been given this role. But in our practice, again, these are things that we need to look into. So some groups of some antibiotics that fall under the reserve group include colistin, fosfomycin, linezolid, meropenem combined with verbobactam, and also polymyxin B. So these are just some of the examples, but there are other examples that fall under this class of antibiotics. Dr. Zoran, back to you.
Thank you so much, Dr. Mudenda. So again, we'll go to our third poll question, okay, and we'll launch it in the next few seconds. So the poll question is asking a question around ceftriaxone. Okay, so just a minute so that we can be able to have the poll question launched. But as the poll question is being launched, I'm sure you can be able to see on the slide the question that we have, and it's asking us on ceftriaxone, a watch group antibiotic is overused in first, secondary, and third level hospitals in Zambia. And again, we have two options, A being true and B being false. So I encourage you to give a response based on what you think. Okay, so currently we have 52% that have been able to respond. So please continue. Okay, we have a few more seconds to go. Okay, we're at 70% of the community having responded. We have a few seconds to go. Please feel free to be able to respond. Okay, so we're now ending the poll. Okay, again, just to thank you for responding. We had 73% of those on the call being able to respond. And let me just share the results. Okay, so we can see that from the 66 that were able to respond, we have 95% saying that this is true, and then 5% are saying false. All right, so thank you for your feedback and responding to the poll. I'll again give Dr. Mudenda to continue with the presentation. Thank you.
Right, thank you so much, Dr. Zoran. So we now go into the final part of our presentation. So on the Zambian scenario, when we look at the AWaRe classification of antibiotics, evidence has shown that in 2022, a study by Mudenda and colleagues in first-level hospitals found that ceftriaxone was the most used antibiotics, and these results have also been reported by a study that was conducted by Karungia and colleagues across the 10 provinces of Zambia, where ceftriaxone was highly used. And recently, the Antimicrobial Resistance Coordinating Committee of the Zambia National Public Health Institute also found similar results across more than 30 first level, second level, and third level hospitals, indicating that ceftriaxone is actually overused in healthcare facilities in Zambia. Now, these findings have got many causes, or there are main reasons for these findings. Of course, it could be one thing which I mentioned about the availability of access group antibiotics. Maybe we do not have access group antibiotics available at all times in the facilities. But also it could be personal experience. Maybe other prescribers feel that when they use or they prescribe ceftriaxone, it works better than other antibiotics. But there could be multifactorial reasons, and those maybe we can discuss as we go towards the end of the program. So in summary, the AWaRe classification of antibiotics promotes the rational use of antibiotics. And adherence to treatment guidelines is very, very critical to ensuring that we improve patient outcomes. And as a country, we need to ensure that we make available the access group of antibiotics at all levels of patient care. And this will help us to avoid overuse of watch group antibiotics. And I'm so happy to know that the Zambian Ministry of Health has now adopted the WHO AWaRe classification of antibiotics, and this will be a part of the STGs, where you find that in the STG now there will be this classification of antibiotics, and it's good for the healthcare family to know that all information relating coordination of the AWaRe framework of antibiotics and also antimicrobial resistance activities are coordinated by the antimicrobial resistance coordinating committee of the ZNPHI. And in terms of dissemination of information, we need to disseminate this information to all healthcare workers, because these are guidelines and they will help us to combat antimicrobial resistance. Many of the times when I've asked healthcare workers and they don't know about this AWaRe classification of antibiotics. So let us work together to sensitize other healthcare workers. And the way forward is that as we use these guidelines also, let us look at the disease burden at the facility level. Let us also look at the resistance patterns, because microorganisms are resistant to antibiotics. So we need to know which antibiotics are not working well, have lost efficacy, and so on. Let us ensure the availability of access group antibiotics at all levels of practice, and let's restrict the use of watch group antibiotics as well as reserve group antibiotics. Because if resistance develops to these watch and reserve group antibiotics, then where do we go as a country? So let us ensure we promote rational use of antibiotics by adhering to the WHO AWaRe classification of antibiotics. And also as facilities, let's ensure we develop our own antibiotic policies. You can have your own antibiotic policy. For example, you have an STG. That's a national document, for example. Okay, you have the Zambia National Formulary. That's a national document. You have the essential medicines list. That's a national document. You can also develop your own at facility level, based also on the resistance patterns and disease burden. Let us develop national and hospital clinical guidelines. These are very, very important. Even if we have good experience, let us follow the hospital and clinical guidelines. And also, we must monitor our stewardship activities and programs. For example, if we have put in strategies to address AMR, we have put in strategies to promote adherence to treatment guidelines and other antibiotic policies. Are we monitoring? Are these strategies working or not? So it's very, very important that we monitor these stewardship programs. So these were my references, where I got the information from. And we can repeat the poll.
Okay, yeah. Thank you so much, Dr. Mudenda.
Sure.
I hope you've been following through this wonderful presentation on the AWaRe classification of antibiotics. So we'll go back and look at the three polls that we launched during the presentation. So we'll start with the first one. Okay, so the first one is asking the question, what is the goal of using the WHO AWaRe classification of antibiotics? Okay, so again, we have 4 options. A being to monitor antibiotic consumption and the effects. Okay, sorry, I can't read the latter part. We can just try to go.
And effects of stewardship programs.
Okay, there we go. And the effects of stewardship policies. Then B is to optimize the use of antiviral agents. C is to reduce the use of antifungal agents. And D, to increase reserve antibiotic usage. Okay, so we are at 40%. That is 40 of 41 now. Okay, please, we encourage you to respond to and participate in the poll. Okay, we've gone past our 1 minute mark. I should be ending the poll soon. Okay, good. So the poll has ended. And we can see that learning has taken place because we can see that 100% of those that participated in the poll have indicated option A as the answer. Dr. Mudenda, you'd like to say something about that?
Yeah, so it's good, Doc. After sharing information, before sharing information, we saw that there were some answers, and a C, which is reducing the use of antifungal agents, and also D, to increase reserve antibiotic usage. Now, after the discussion, I can see that everyone now has opted to say it's to monitor the antibiotic consumption and also stewardship policies. I think this is good, Doc.
All right. Thank you so much. Again, we appreciate to everyone that has been able to participate in this poll. So we'll launch the second poll question. Please, I encourage you all to be able to participate. Remember that it's for learning purposes, and also it helps us to know whether we've achieved the objective of our presentation. So second poll, just to remind us what the question was the question is asking on the watch group antibiotics and if they have a high potential for resistance compared to access group antibiotics. Okay, so we have a minute. We'll give you time to be able to give your responses. Again, we encourage all of you to participate. Okay, we have a few more seconds to go. Please feel free to be able to indicate what you think is the correct option. Okay, so it's a minute now. We'll be ending the poll. Okay, so let me just share the results. Okay, so we have 59 of the 99 on the community on the call who have responded, which is translating to about 60%. And we have 83% that are saying this is true. And then we have 17% that are saying this is false. Dr. Mudenda?
Yeah, so for me, I can conclude based on these results, I see, I'm sure our colleagues who have said false, it's because maybe they're looking at the usage, as in we have to use more of access. That's when we go to watch, then we go to the reserve. But in terms of resistance potential, the access group have low potential compared to the watch group antibiotics. And that is why we discourage overusing watch group antibiotics. We're saying when we're using these, the potential to develop resistance is very high, okay? And this is a problem we are trying to avoid. So those who say it's true, that's the correct answer.
Okay, yeah. Thank you so much, Dr. Mudenda. And I must also believe that I think at the beginning we did have lower numbers.
Yeah.
So probably these are people who might have joined in a bit later.
Yeah.
So again, thank you for your participation. So we're going to launch the last poll, which is, okay, so we're launching the last poll. Okay, good. So the third poll has come in, and it's looking at ceftriaxone, a watch group antibiotic, which is being overused in first, secondary, and third level hospitals in Zambia. And the options are true or false. So again, we have a minute to be able to respond to this poll. We encourage you to all participate. Okay, thank you for the participation. So far, we're at 56%. Okay, so we'll be ending the poll now. Okay. All right, so again, we have 65, that is 68% that have been able to respond to this poll question. And it was looking at ceftriaxone, a watch group antibiotic, being overused in first, secondary, and third level hospitals in Zambia. And of the 65 that responded, 98% are saying this is true, and then 2% are saying this is false. Dr. Mudenda.
Yeah, yes, this is expected. I'm sure, there are also certain facilities maybe that do not overuse ceftriaxone. So you find that maybe the one response is from such a facility. So otherwise, from the evidence which we presented, showed that ceftriaxone is being overused in facilities in Zambia.
All right, thank you so much. So stop sharing the results. Okay, so just a brief summary of what we were looking at, especially to those that joined us a bit late. So we had Dr. Mudenda, who took us through the presentation on the AWaRe classification of antibiotics. And he did remind us that in 2017, the World Health Organization decided to develop the AWaRe classification. And the purpose of this classification was, number one, to help with optimizing antibiotic use. Number two, this would then be able to lead to improvement of patient outcomes. Number three, to reduce antimicrobial resistance. And number four, to be able to help with the limiting of the spread of these multi-drug resistant organisms. And he did take us through, I think the main objectives of this presentation was to help the community to be able to know what is within this AWaRe classification. And he did highlight that there are three components in this AWaRe classification. Number one, he did mention that we have the access group. Then we have number two, the watch group and the reserve group. And he reminded us that when you think of the access group, this is referring to the empiric first and second line antibiotics, which should be widely available. And when you look at how these costs, they tend to have a much lower cost. And when you look at the potential of these antibiotics to develop resistance, it's quite significantly reduced. And therefore, the recommendation is that we need to be able to use more of these antibiotics in management of these most common infections. And I must just ask Dr. Mudenda, in case one is wondering, to what percentage or to what extent should we use these, or if one was to conduct a survey in an institution, what percentage of patients should be on these drugs in the access group?
So for the hospitalized patients, when you conduct a survey, you must find that most of them should be on the access. That's 60%. 60% of the patients should be on access group antibiotics. Then 40 must be on either they should be on the watch group antibiotics, especially maybe 35% on watch and 5% on reserve. When you find such, then you are okay.
All right. Yeah. Okay. Thank you so much. And so he's reminding us that if you sample 10 patients, 6 of them should be on antibiotics in the access group. Sure. So then he moved us to look at the watch group and also the reserve group. So thank you again. So we'll now quickly open it up to the participants to be able to ask questions, maybe 1 or 2 questions, then we can be able to move to the case presentation. Okay, so we have a question from Kefas Mwanza. Please go ahead.
Thank you very much, team, for the wonderful presentation, and very, very important in this time.
Thank you.
My concern has been with regards to ceftriaxone misuse. I'm very happy that we made reference to some of our local studies, but most importantly, from our side, we always want to relate the finding to patient-centered clinical outcomes, meaning this word misuse, is it attributed to mortality outcome? Is it attributed to development of adverse effects with use of ceftriaxone, or was it associated with development of resistance? Because if these three were not observed, then it becomes very difficult to say misuse. I submit. Thank you.
Thank you, Dr. Mwanza. Okay, Dr. Mudenda, would you like to?
Yeah. Thank you so much. Just that based on the given time for the presentation, I would have also given some examples where ceftriaxone resistance was reported. So from, again, locally conducted studies have shown that from all the tested antimicrobials, one of the antimicrobials that has that's shown a high resistance was ceftriaxone together with Septrin. So this is in the human healthcare. And again, you go in the animal health, again, the picture is the same. So you find that resistance to ceftriaxone is quite high. Ampicillin, ceftriaxone, and Septrin, quite high. And the picture you're looking about in humans and animals, still the same. So there is some evidence, sir, that there is a high resistance to ceftriaxone. Basically, we can say this is because to the overuse of ceftriaxone.
All right, thank you. I hope that's been able to address the question that you have. So only allow the last one from Clara to be able to comment, and then I don't know if it's a question or a response to the question. Please, Clara, go ahead, and then we'll move to the case presentation immediately. Clara, if you're speaking, you're still muted. Kindly unmute your gadget and then be able to contribute. Okay.
Well, it's muted.
All right. Okay. We hope you can be able to bring the question maybe later after we have the case presentation. So at this point, I'd like to thank Dr. Mudenda, and then we transition to the case presentation. And to help us take us through this in the next 10 minutes, we have Dr. Bwaliambulo, who is a registrar in internal medicine and infectious disease here at University Teaching Hospital, and she'll take us through the case presentation. Please go ahead.
Good afternoon, everyone. Thank you very much. I'm Bwaliambulo. As said, I'm taking you through a case presentation to partially relate to the discussion that we're having today. Thank you. So my patient is a female, 27, chondrodysplasia patient with chronic osteomyelitis of the left femur, which is secondary to a non-union pathological femur fracture. She sustained it about 1 year ago, last year in 2023 May. So when I saw the patient, she was benign post external fixator explantation and wound debridement, which was also inserted at that time about 1 year ago. On presentation, my patient had fever, chills, and left lower limb pain for 4 days. And she has RVD-NR with no non-comorbidities, not diabetic, not hypertensive, not sickle cell disease. She's a non-alcohol and non-smoker. On examination, her temperature was 37.7, the pulse rate of 96, respiratory rate 22, had good nutritional status, was awake, alert, mildly pale, and not in distress. Her chest and CVS exam was non-remarkable. On local exam, she had a left femur necrotic bone that was exposed with wound and some obvious past discharge. Next slide. the clinical timeline and the antibiotic exposure she got. So this is a patient who was on ceftriaxone that was started from the 10th of August up to the 23rd. That was about 13 days. And also, sorry, the other, yeah. So the other blank part, that was metronidazole that she also got. And she had also received Cyprobid, which is ciprofloxacin, that was on the 16th up to the 23rd of August. And of note, she had also received some cefotaxime, which was alternated with ceftriaxone, depending on what was available at the pharmacy, according to the explanation I got. And the definitive therapy, the one that is stated, came in after the culture that are following, which was imipinam, cilastatin, which was started, that was on the 24th, and she's still receiving it. Her lab results, we had a white cell count of 6.3, and the absolute neutrophil count of 3.3, hemoglobin 8.4, platelet 44, urea was okay, 3.5, creatinine was okay, liver function was okay, said she's RVD NRA, 2 gene expert was negative, RPR negative, chest X-ray was normal, and she had the left femur X-ray, which had a sclerotic bone with sclerotia and involuculum. So microbiology results, which was the deep tissue culture that was gotten, that was on the 19th of August, and the results came, that was on the 8th. So it was a deep tissue culture that was collected from the wound site, which is a proximal femur. And the microbiology results include 2 organisms. The first one was a Citrobacter brandy, which is a gram-negative anaerobe bacilli. And it showed a sensitivity to imipinam, tetracycline, and cotrimoxazole. And there was an intermediate to levofloxacin, amikacin, and resistance to ampicillin, sulbactam, gentamicin, ceftriaxone, ceftazidime, and cyprobid. Skip. Yes, that one. So this was the other organism also, Pseudomonas, which was sensitive to amikacin, imipinam, and levofloxacin, intermediate to cefepime, ceftazidime, and cipro, and didn't show any resistance for this one. So assessment, this was a female 27, RVD NRA, chondrodysplasia patient with COM, proximal left femur, 1 week post-external fixator explantation, presenting with sepsis, and local exam was significant for a left femur necrotic bone that was exposed with wound past discharge. So our questions for this patient, what we wanted to bring out the discussion points was the first one, when do you decide to remove the hardware in patients with chronic osteomyelitis? The second one is, does past discharge mean infection? And the third one is it realistic in our setting to give empiric antibiotic treatment for only 3 days as per WHO recommendation? And the fourth question is, what is the duration of antibiotic therapy in COM? Thank you.
All right, thank you so much. So we have some questions from the case presentation. Again, to thank Dr. AWaRe for this wonderful presentation. So we'll start off by discussing when it is right to remove hardware in chronic osteomyelitis. Okay, so Dr. AWaRe, how do you want us to discuss this? Do you want us to throw it to the group?
I think you have time.
Okay. Sorry about that, Clara. We'll try to ensure that you can be able to unmute. Otherwise, thank you for the question that you had wanted to ask. I think we'll be able to give you an opportunity later. Thank you. So we have the first question, and we have a number of experts as well on the panel, as well as those part of the community. would anyone would want to respond to the first question, which is asking us, when do we remove hardware in chronic osteomyelitis?
So, our experts there.
Do we have any of our experts on the call? Dr. Kapolowe, are you there?
Look, while we wait for the experts to maybe chime in, it might do to have Clara's question asked now.
All right, thank you. Thank you for that. Clara, please, you can go ahead, even as we think of the 4 questions. I hope you'll be able to
Good afternoon.
Yes.
My question is, as the lab, are we also supposed to be following the WHO AWaRe classification whenever we're testing for susceptibility?
Okay, thank you. I think that question is directed to Dr. Mudenda. So, okay, so we also have a Kaunda on the panel of experts. Are you able, please, to respond to the question that Clara has raised? Is Kaunda on the call?
Do we have someone from my, but I can take it.
Okay.
Yeah.
Hello? Hello? Maybe I can make a brief comment.
Yes,
This
please.
is Francis.
Oh, please go ahead.
Okay, what it is, at the moment, we've been advised, like if you are doing surveillance, we put all the drugs that are in the glass, that are in the glass. But now, after testing all those things, you have to give the clinician the first generation. If the first generation is sensitive, that's what you submit. If the first generation, second generation has resistant, you put them all there, then the clinician will decide what to do. I submit.
Thank you so much, Mr. Ngulube. I think you've said what was on our minds as well. Yes, we are using the glass, and then for submission, we follow what you've said. Thank you for that. Okay, so with Clara's questions hopefully has been answered. We come back to our questions. So anyone from our panel of experts, please, can we be able to respond to the first question? When do you remove hardware in chronic osteomyelitis?
I can take it.
Okay.
So I think that's a good question, and I wish we had our orthopods, because as infectious diseases, we are always called to answer these consults, and it's a very difficult question. First of all, hardware. I noticed we used a lot of words that we use in ID, such as explantation, which is removal of the hardware. It's very expensive. It's an expensive procedure to put in, and also removing it. You can imagine they're paying for theater. The hardware is as well. Sometimes they have to import it. So one, it depends on the type of hardware. Is it titanium? What are they using in there? What metal has been used? But more importantly, I believe Kefas, nice to hear you, talked about patient-centered care. So we remove them. One, usually we are called because of infection. But sometimes if the underlying bone has failed to heal, you may need to remove that hardware. And also pain. Sometimes the hardware may have pain. So in the context of infection, if the infection doesn't heal, it also depends on the country guidelines. So each country has different guidelines, like the US, the UK, they have different guidelines, and the orthopods. So it's actually a multidisciplinary decision. So sometimes, as I do, we may say, remove this hardware if we have a Staph aureus, an MRSA, because we know it's very sticky. We know there will be a biofilm. But if it costs them a lot and they are more comfortable with going in, doing a wash, and sometimes they may not have a replacement for that. So it's in short, multidisciplinary decision. There is no hard and fast rule, but infection is one of the commonest reasons we remove hardware, but it's not always removed, because as I do, we can make a recommendation, and it's up to the surgeon to say we are going to remove this hardware. And remember, there are different parts of the body a hip is very different from a spinal hardware because the risk is much, much higher when they go in and out. Yeah, in summary.
All right.
Let's go.
Thank you so much. Thank you for that response. So we'll move on to the next question, which is asking the question, does past discharge mean infection? Does past discharge mean infection? Again, we'll ask anyone from our panel of experts to be able to respond to this. We have Dr. Matele on the call. Or do we have anyone who would want to respond to this question?
Come, Rachel.
We're kindly asking if you could ensure that your gadgets are muted. Thank you for that. Does past discharge mean infection?
No. Afternoon, networks. Quite right. We get to see that usually when there is past infection, when there is past discharge, be it a sinus, be it a wound or something, you get to notice that usually it's a collection of debris, dead material, and also bacteria and all that. And you find that it will be coming out from a certain segment of the body, and it may be with some systemic symptoms and all that. But generally, when there is past discharge, it means that there is an infection. Yeah.
Okay, thank you. We also have a few responses on the chat. So I'm not sure who it says albino. Okay, it does mention that yes, past discharge means infection. Okay, so if there are no other contributions, we'll move to the third question, which is asking the question, is it realistic in our setting to give empiric antibiotic for 3 days only as per WHO recommendation? And remember, when we go back to the case presentation, you will see that our patient was on quite a number of empiric antibiotics. If you look at ceftriaxone, we're talking of from the 10th to the 23rd. So that is translating to about 13 days, okay? And of course, this was being alternated with cefotaxime as well as Cipro. So now we come back to a question which is asking, is it possible in our setting or realistic to be able to only have empiric antibiotic treatment for only 3 days as recommended by WHO? So we'll start with our panel of experts, and then if there's also any contribution from anyone from the network, please feel free to contribute, introduce your name, and then you can give us your contribution. Okay, so maybe in the interest of time, yes, please.
Okay. So this is a question that I think all of us should be thinking about, because if you give empiric therapy, it means that at some point you will get into definitive therapy, right? So in short, is it appropriate for us to have an empiric window of 3 days, then expect a result to come back from the lab and give you targeted? I know Francis is there, and he will talk about turnaround times, because it means your human resource capacity. What can your lab do? So that really, it's very contextual, and it's a very important question. And that's why we need guidelines that are more appropriate. But obviously, this is ideal. If you can get 48, 24, that's better. But as our system is improving, we are getting closer and closer to this. So it also depends. Are you talking about a bacteremia? While it may not be realistic for a setting, it is the best. You know, you don't want to go on empiric therapy and end up with antimicrobial resistance. I think we've gone through this. In terms of realisticness, this is a systems issue. And I would like people like, I don't know if Joseph is on, and I can tell you for UTH, it depends on the site, right? That you are talking about, and the sample that you've sent. Is it a blood sample? Has it flagged in the lab as well? This is, I think it's an emotional question. Somebody who's in Kanyama may tell you that this is not a realistic guideline, isn't it?
Yes.
Because they do not have access to the lab. That sample has to come to this. So it's a system question, I feel. And I think maybe we should be asking, is this a realistic target? Is this something we should be targeting? What is the disadvantage of having a longer empiric window than, 3 days? Of course, we know the issues with that. You may be completely off with your bag, right?
Yeah.
So realistic, maybe not. It depends. Am I in Katete? Am I at UTH? Sometimes I do get a turnaround of less than 24 hours and I get targeted. And Michael should help us answer this, because Francis can tell me that I've seen gram-positive cocci in chains. You see what I mean? And I should be able to start thinking, what should I be using in my definitive window? So it's quite it's a complex question. I think it is desirable, realistic, maybe not, but over time, I've noticed that we are getting better.
Okay. So, Dr. Somba, in short, you're saying it's yes and no.
Yes, I think it's a yes and no.
Yeah.
Is it appropriate? Maybe you need to be meeting this target, because obviously there are issues with that.
I've seen also Miss Ruthie Nakazwe.
Yes.
Madam, what would you say about that? Since you are from the lab as a biomedical scientist, but I know you're a microbiologist. Ms. Nakazwe.
Are you still with us? Or maybe as she's arranging, maybe Francis, Mr. Ngulube, are you able to maybe just give us a picture of where we are as a country in terms of microbiological testing?
Or anyone from the lab?
Is Kaunda there?
Is Kaunda on the network? Kaunda?
And I believe microbiology is the most appropriate.
Yeah.
Because my empiric window is as long as I don't have a definitive diagnosis, I'll go on. My empiric can even be 2 weeks, because I don't have anything to do.
Hello?
Yes.
Hello.
Hello?
Hello.
Okay, from my own opinion, I don't have the number, but I would say microbiology testing in the country is very, very below par. That's what I can say. I submit.
All right.
But it's uniform, Francis. Of course, I think as a country, we are around in the 20s, but is it uniform? Because if you are in a private lab, you may find, and if you're using molecular testing, it's even shorter. Right? So it's quite a packed question.
Yeah.
So, Dr. Kandozla also trying to respond.
Okay, so
yes, I was. Sorry, it's just that I'm in a bit of a noisy place. That's why I wasn't able to talk. So I think everything has already been discussed. It depends on the capacity, diagnostic capacity you have at the country. And as these talks have been going on, it's not everything that WHO publishes that is suitable for each country. We have to think of what type of economic situation are we in. So for low and middle income countries, there are certain measures that we can put in place. I think Dr. Mudenda mentioned about the strong or functional AMS programs, because if you have that, even if you don't have your results by day 3, at least there should be some sort of indication where notes are written to say we are continuing this antibiotic because we do not have lab results or the patient is responding. So there should be different parameters that you're following. Clinical response, is there clinical response, is there no clinical response? And if by day 3 you're not able to change, at least there should be a review by day 5 not whereby a patient is on the same antibiotics for 10 days, 15 days. So it means there's no AMS program that is working properly. That's my submission.
All right, thank you so much. So for the last question, I'll probably ask Dr. Mudenda to help us respond to this in the interest of time. We should be winding up now. What is the duration of antibiotic therapy in chronic osteomyelitis?
I was actually thinking about Dr. Sombo.
We see these patients all the time because it's born. In general, we recommend 6 weeks. That's a general answer. If I'm dealing with a fungus, that can even prolong.
Okay.
So in general, we prolong more than the usual 4 to 6 weeks.
Okay.
All right.
The recommendation is actually 6 weeks.
Thank you, Doc.
Thank you so much, Doc, for that response. So just to thank everyone who's been able to join us on the network. Thank you so much to our IT team. Thank you to Dr. Mudenda, Dr. AWaRe. We really enjoyed the presentations and the wonderful engagements. To the network as well, we thank you for being able to join in. Our IT team as well, thank you so much. We hope you've been able to pick up 1 or 2 things. And just as a reminder, we'll have our next ECHO session on the 18th of this month. And it is a wonderful presentation looking at antibacterial agents. I encourage you all to be able to attend, not to miss this one as well. With that, we come to an end of our ECHO session today. Thank you so much to everyone. Bye.
Please join us in the hub next time.
Oh, yes. Oh, yes.